this useful map with some excellent resources. If we look at the patient care information, there is an excellent leaflet from the AF Association, the stroke risk calculator, which gives patients their individual stroke risk. And finally, we've got the fantastic leaflets from the AF Association on the individual NOACs. These can be sent in advance of any meeting so that patients and their relatives can look at the risks and benefits of NOACs. The key message here really is that aspirin is really of little use, that you should be doing a CHADS2 VASC and or a HAS-bled, and that a rate control strategy really is the preferred approach rather than a rhythm control strategy. You can start with a straightforward beta blocker like bisoprolol 2.5 milligrams once daily, and if they can't tolerate beta blockers, then you can give a rate limiting calcium antagonist. If we just go to the very first box here, we've also got the GRASP AF tool as well as links that you would expect. Now, the initial tests should include things like some bloods and a thyroid function, ECG, and only consideration of a chest x-ray or echocardiogram. If we look at the local formulary, we've put in the sort of doses you need to be giving, and also that the resting heart rate, this is in persistent AF, should be between 80 and 90. Interestingly, if it's paroxysmal AF, the heart rate is a lower target, which we'll look at in a minute. The classification of paroxysmal, persistent, permanent and lone is defined. The diagnosis and management, as we've said, resting heart rate if you have paroxysmal AF of between 50 and 60. The risk assessment scores consist of the CHADS2 VASC, and there's a link, an explanation of what they are, and the fact that vitamin K can be used to antagonize warfarin, but unfortunately not the NOACs. Finally, there's referral forms to the anticoagulant clinic and referral forms to cardiology, ambulatory ECGs and echocardiography. Thanks for listening.